Welcome to the Satellite Symposium on new insights into the epidemiology and treatment of candidemia and invasive candidiasis. We have two speakers for today's session. Jennifer Salo, who is an assistant professor of medicine, transplant ID specialist, Division of Infectious Diseases and International Health at Duke University Medical Center. She will be presenting updates in epidemiology, diagnosis, and healthcare burden of candidemia and invasive candidiasis. And that lecture will be followed by Sam Aiken, who is assistant professor of medicine, clinical pharmacist, specialist in infectious diseases, Michigan Medicine, and adjunct clinical professor of medicine, University of Michigan College of Pharmacy. And he will be presenting advances in the treatment and outcomes of candidemia and invasive candidiasis. I'd like to introduce Dr. Salo.
Thank you. Hi there. Thank you so much for the opportunity to come and present for you today on a really exciting topic, I think, in terms of Candida epidemiology. Let's see. Just one moment. So I have no disclosures, and the objectives are as listed. And I'm really going to focus today on the first two objectives, and my colleague, Dr. Aiken, is going to be talking with you extensively about the third. And I'm going to spend some time in the next 35 minutes with kind of some broad strokes and maybe updates, and so far as the spectrum of disease, some of the important epidemiologic shifts and changes, some ideas around diagnostics and what we're using and what we hope to use in the future, and then all throughout kind of talk about the burden of this organism and in this infection in our populations. I'll preface all of this to say that I'm an infectious disease doctor working mainly with transplant patients, and I'll try not to focus too much on them, but I'll have to tip my hat to them once in a while throughout the presentation, because that's kind of what I do all day long. So I think before we start, it's always important just to define the spectrum of disease, and with invasive candidiasis, there's candidemia and there's deep-seated, and these are not mutually exclusive. Some would say a third fall into kind of each category listed here, those with candidemia without deep-seated candidiasis, those with both, and those with just deep-seated candidiasis. And disseminated and deep-seated candidiasis can affect essentially any organ system. And when we think about kind of pathobiology and how pathogenesis and how this it evolves, it relates to perturbations in our microbiota, in the barriers, our GI barriers, our skin barriers, as well as some of the things we do to patients in terms of exogenous immune suppression. And I think this figure demonstrates it really nicely in terms of just, see if I can, the sites in which that we see Candida enter the body. One is what we think about most commonly with the kind of prototypic Candida albicans in terms of it being a commensal and translocating across our GI flora. It can result in local infections in the GI tract or extend into the blood with deep-seated infection elsewhere through dissemination. We definitely see this in our ICUs and in the healthcare setting, in the setting of catheterizations, where we have perturbations in our skin protection and boundaries, and it can form biofilms and leach out from those biofilms and resultantly disseminate. And then less commonly, we might see it ascend from the GU tract in terms of ascending pyelonephritis, which may remain localized but may also disseminate. So I'm tipping my hat just one time. I'm going to throw in some interesting cases that we've certainly seen. The first is a neutropenic patient with AML on fluconazole prophylaxis who developed acute disseminated candidiasis. And there's lots of ecchymosis on this arm, but if you look closely, you can see these small papular lesions, and biopsy of those demonstrated Candida krusei alongside blood cultures. And again, we know that it's intrinsically resistant to fluconazole, so you might anticipate that this might break through. The second case is a really interesting case that we had, again, a rare manifestation of Candida. It's meningoencephalitis. He was a liver transplant candidate who had in the preceding months, Candida dublinensis candidemia, and then presented 2 to 3 months later with just confusion, that people were really passing off as hepatic encephalopathy, and ultimately had an MRI that you can see here in the on the T1 images. You see this kind of leptomeningeal enhancement around the brainstem, and then even more impressive on his T2 images, there's marked ventriculomegaly, and you see this marked edema around the ventricles themselves. And then lastly, a very tricky diagnosis to make, and these slides remind me of how tricky this can be, as chronic disseminated candidiasis, typically seen in patients with prolonged neutropenia and as their counts recover. And oftentimes, in only 15-20%, are they actually candidemic. And so there's a host of things that can actually cause these findings. The bottom case actually was an AML patient that was neutropenic, and the MRI is kind of studded there with these T2 hyperintense lesions in the liver and spleen. But interestingly, this patient here was a myeloma patient that had had VD PACE, was profoundly neutropenic, and ultimately we ended up biopsying, and it was myeloma that was in the liver. So just be aware that not all things are candida when they present in such a way. And so I think the incidence of invasive candidiasis is quite relevant in today's society, both in the United States and across the world. It's the fourth most common pathogen associated with healthcare-associated infections in the United States, and can be associated with substantial morbidity and mortality. Now, attributing direct mortality to Candida is often difficult. These patients have multiple comorbidities, and there's lots of things that could, for lack of a better word, take them down. And attributing that to Candida is oftentimes quite difficult, and so sometimes it's an overestimation of the attributable mortality, and sometimes an underestimation. And part of the reason that we think the incidence is underestimated is our diagnostics, and we'll talk about what we need to do to improve that. And that some of the cases that we're actually seeing now are more in the community. We'll talk about IV drug users. Much of that's not collected in the database. We're doing a lot of OPAT therapy, and cases might be occurring in the outpatient setting. And then I'd like to focus for a moment on some really nice data from the emerging infections programs. It's a population-based surveillance that's done through the CDC, and they were trying to just estimate the sheer burden of organism of infection for candidemia in the healthcare setting. And in 2017, they estimated that there was over 22,000 cases with an incidence rate of 7 per 100,000, and a rather substantial all-cause mortality, with all the caveats that I mentioned in regards to attributable mortality. But that's just candidemia, which is just one slice of the pie, right? One slice of the puzzle here in terms of candidemia and invasive candidiasis, which incorporates all the deep-seated infection. And look at the numbers when you compare that to other common healthcare-associated infections like C. diff and MRSA. So something really to take note of, that it is a notable problem in our healthcare system. So we'll stop for a question. Which of the following is an established risk for invasive candidiasis? Broad-spectrum antibiotics, central venous catheters, prolonged ICU stays, or all of the above? I think there's audience participation. Is it electronic, or are we doing a raise of hands? Electronic, okay, sorry, oh, sorry, okay, all the above. Okay, well, so I can leave now. You guys, you've got this. So you're exactly right, all of the above. Let me see if I can advance this. Oh. So there are, established risks which are common and very nonspecific amongst these patients. We've mentioned some of these already in the question that I posed, and I've listed them here. But there's a lot of evolving risks that I think we can learn a lot about, sort of mechanisms of candidemia and candidiasis through. Two of which that I want to focus on today are recreational drug use and COVID. But there's multiple others. There's a lot. We could spend the whole hour talking about host genetics and its relationship to this, but we're not going to. And then I did tip my hat one more time. In your packet, I put a case in there of an honorable mention of a risk for candidiasis, which is donor-derived disease. We had a recent case of a donor-derived infection with candidemia. It was a heart transplant recipient, and the heart transplant recipient unfortunately underwent significant complications from that donor with disseminated candidiasis and mediastinal involvement, so I've listed that reference in your handout. In terms of infectious drug use, there's a lot of really neat data that's gotten published of late. And interestingly, despite the fact that such a small population, a small percentage of our population use IV drugs, they do account for up to 10% of the candidemia cases. And we know that that's actually an underestimation because many of these patients don't get recorded in our current databases. And so I chose, again, some data from the emerging infection program through the CDC, where they were looking at the changing epidemiology in candidiasis and infection drug use. And you can see from this slide, when you look at the proportion of cases with candidemia that had recent drug use within the past 12 months, a substantial proportion of patients in some of these states. There's 9 states that they looked at. If you look in New Mexico, over 30% of those patients, now maybe not so much in Minnesota, but a real issue. Moreover, they looked at the data in comparison from 2014 to 2017 in the 4 states that I've noted there with asterisks. And there was a 2.2-fold increase in cases associated, in candidemia cases associated with IV drug use. So the opioid epidemic is real, and it's impacting us in terms of the secondary infectious complications. Looking to see if these infection drug users had differences in terms of their epidemiology. Well, when you compare it to studies in the 70s and 80s where it was pretty monomicrobial with Candida albicans, there's a nice splay of different candidemias that you see in these patient populations. You'll also notice that you see more Candida parapsilosis than you do glabrata, which makes sense. These tend to be younger patients. They're outpatient. They're not necessarily exposed to the healthcare environment. And we tend to see glabrata in these older patients with multiple comorbidities and extensive exposure to the healthcare system. And the other thing we note about this population is it oftentimes is associated with recurrence. So I'm going to switch gears in terms of risk and talk about COVID. I try not to talk too much about COVID. I think we're all trying to take a deep breath for a bit and not. But certainly in 2020, the WHO declared a global pandemic with COVID-19, the infection caused by the respiratory virus SARS-CoV-2. And US data based on as late as April of this year showed that over 100 million cases and 1 million deaths were associated with COVID. And we know these patients, oftentimes, a percentage of them, up to 5%, can get quite sick and necessitate ICU admission. But interestingly, they are 2 to 10-fold more likely to get invasive candidiasis than patients without COVID. And so it's not a problem just in the United States, it's a problem worldwide, and I show you some headlines from Italy, Taiwan, Brazil. It's happening all over the world that we're seeing these increased uptick in invasive fungal infections in patients with COVID-19. And there's another neat study that was put out by the CDC where they went back and looked in a pre-pandemic and then a pandemic cohort to try to compare this incidence of invasive candidiasis in that population. And interestingly, in the pandemic cohort, 25% of the patients with invasive candidiasis had COVID. So it's a real issue. The risk factors might be a little different than what we see in patients without COVID in terms of the lack of the patients with underlying malignancies, transplantation, and things such as this. And while we think of invasive candidiasis often being diagnosed in the ICU, it was more commonly diagnosed, I think understandably, or something you might suspect in patients with COVID-19, and had pretty substantial associated all-cause in-hospital mortality. Some other neat things that the study showed, if you look here at the histogram on the left, the x-axis is the days post-admission, truncated at 40 days, and the y-axis is positive cultures, is that in patients that are in the pandemic phase that had COVID and had candidemia, they tended to occur later in their healthcare stay. So if you look at the median onset in the pre-pandemic or the pandemic without COVID, it was 4 days as opposed to 14. And I think this really tells us what our healthcare system and what we're doing to these patients to manage their COVID does to their risk of invasive candidiasis. And looking at the different species of Candida that they have, there really hasn't been any suggestion of a change in terms of the epidemiology. This is pre-C. auris uptick. We'll come back to that. And then, just looking at some publicly available vital statistics, I think it's interesting to look here at fungal deaths with COVID-19 deaths superimposed. And you can see here, when we find surges in COVID-related deaths, along with that, we see surges in fungal deaths. And most of that's driven by either invasive candidiasis or invasive aspergillosis. And so this last slide is just a bit of an amalgam of all the things that we were thinking about insofar as COVID-19 and its relationship with with Candida and invasive candidiasis. I think some of these established risks are quite obvious. Breaches in infection prevention were, in many situations, unavoidable. And then many of the things that we're giving patients to improve their outcomes with COVID are rendering them at risk for invasive candidiasis, such as steroids and tocilizumab. And then a really, really fascinating area are the direct effects of COVID itself, both on the dysbiosis of the microbiome and some of the impacts that it has in terms of monocytes and cytokine production directed specifically against candidiasis that might render these patients more susceptible to invasive candidiasis. And so I'm going to pause again for another question, and we're going to change gears and talk a little bit about the microbiology and ask you guys the most common Candida species worldwide associated with infection. Is it albicans or is it the non-albicans species that have emerged? It's a little bit of a trick question if you consider all the non-albicans together. But you're correct, So Candida albicans. So there's multiple surveillance programs that are available. Each of them have their pros and cons, their flaws. I think it's important to realize that worldwide we really lack a well-defined denominator as to how to best define the epi of these populations. And there are multiple concerns, and I think Sam will talk a lot about this in terms of considerations when doing treatment, but specifically the emergence of novel species such as Candida auris, which is maybe not so novel anymore, but we will certainly talk about it, as well as the emergence of resistance. And so I would be remiss if I didn't mention the nomenclature. I'm not going to focus on the nomenclature because I find it incredibly confusing. But as you all know, with the advent of molecular technologies, it's sort of revamped the way we categorize, identify, classify fungi, and specifically Candida. And so for the purposes of our presentation, I think both Sam and I will refer to these organisms how we would normally, how we have always referred to them, but do know that there is an ongoing reorganization and that multiple of these have been defined to new clades. For example, Candida albicans, Candida parapsilosis, and tropicalis have essentially remained under the Candida umbrella, but things like Candida glabrata have been relegated now to the, and I'm going to butcher the Candida krusei, but the Nacosomyces clade. And so just to be aware that these things are changing. I think actually Candida krusei's name has changed like 3 times in the past 3 years. So, but for now and for the purposes of this talk, we'll stick with what we have. And we know that while Candida albicans remains the most common on whole, there is an increase in the non-albicans species. I think it's best demonstrated by the Sentry data, which is a global population-based surveillance that spans a period of 20 years, and it looks at data from the United States, from North America, from Latin America, from Europe, and from the Asia Pacific. And what we've seen across time is that, in general, the most common Candida species have remained largely the same. Candida albicans, followed by glabrata, parapsilosis, tropicalis, and then Candida krusei being the least common. But it's also important to note that this is very dependent upon geography. So if you look, for example, in Latin America, glabrata is not the second most common organism. And in fact, you see more Candida parapsilosis and tropicalis. And actually, they're having more issues with resistance emergence in their parapsilosis than perhaps the United States right now. So important to think about in terms of the patient you see, where they are, where they've traveled, a little bit more of the epidemiology, as well as focusing on the epidemiology of your own facility. The thing that the Sentry data showed that it's also out in the data that I'm presenting here, which is, this data comes from a little bit different, it's a Cerner Health, which is a electronic medical record system, and it's over 60,000 patients, or actually more than that, that are accumulated from the United States specifically, and they similarly show that there was no change in incidence of these different organisms across time, but that we are seeing an uptick in other species. So not the 5 most common Candida species, but these other Candida species. And I think about this clinically, I feel like we're seeing this. This is an example of this, and it's not a great picture because he had his face right there, and I was afraid you'd see it. But this is a patient that came in with IV drug use, had polymicrobial bacteremia, including Candida. We stuck a needle, did an ultrasound, found fluid, stuck a needle and drained that, and ultimately this patient had Candida blankii, which is an uncommon pathogen, but we're starting to see a lot more of these less common non-albicans species emerge, and this data would support that. So I'm going to switch gears again and talk about Candida auris. And what's the fuss? Why are we talking about it? So if you do PubMed hits, you see that there has been an exponential increase in the amount of data that's been published about Candida auris. There are lots of reasons for that. One is the rapid global spread, and we'll talk about that in the slide that follows. Also issues with heavy colonization of patients and thereby colonization of the environment. And we're seeing it being associated with healthcare outbreaks like we've never really seen before with with Candida, particularly not Candida albicans. It has multiple virulence factors, and again, I think a very exciting area to look at in terms of why these patients may not respond to therapy, even though the isolates may be susceptible. It's been associated with significant morbidity and mortality, very difficult to tease out because it often colonizes the sickest of the sick, these patients in extended care facilities on vents. And then I think we'll talk more about it in the next section about resistance to antifungals and the difficulties we have in identifying the most ideal regimen for these patients. So this is just a timeline. The point of this timeline is really to say, was first isolated in a patient in Japan from an ear culture. We have seen rather rapid and simultaneous discovery of 5 separate clades, genetically distinct and very separate geographies emerge. And now it's present in over 45 countries and 6 continents. I think if you just look at the United States, it started as an outbreak in Chicago metropolitan areas and New York, and now over half of the states in the United States are affected, and in some places it's now endemic. And this is probably best reflected in a really nice publication and presentation recently in ICAC by Dr. Lyman and colleagues, where they essentially demonstrated that since the initial months of COVID, where we kind of saw a lull, we've seen a marked increase in both clinical cases and screening cases in terms of Candida auris. And then there's a lot of interesting data in terms of stewardship and and infection prevention about how heavily colonized these patients are. And basically what these 3 figures show on the left is that if you look at Candida auris, which is in red, if you look at Candida auris, which is in red, they attempted to kind of clean the rooms in patients that are colonized with Candida auris. And within 4 hours, when they looked at things close to the patient, the overhead table or the call button, they were rapidly recontaminated, just the marked burden of organism that is on these patients' skin. And then the resistance piece, and I'm not going to talk too much about this, but just to say resistance is a real problem. Over 80%, based on ARL data, over 80% of these isolates are azole resistant, in the mid-20s are amphotericin resistant, and really low levels right now of a kind of candidin resistance. Often this is dependent upon the clade, and for example, here in Florida, I think the primary clade that you guys are seeing is the African clade, the clade 3, and that is associated with pretty high levels of azole and amphotericin resistance, as opposed to places in the Midwest that are dealing with other clades. So in terms of Candida diagnostics, so I think we all have established or agreed that this is a problem. Candida is a problem. And we have a lot of ways that we can diagnose it, but we could do better. And I think, when we think about blood cultures, they're actually quite sensitive. And so if you think about group 1 in this Venn diagram, our cultures in patients that are actively candidemic are going to catch most of those patients. But the problem is they'll only catch about 50% of the patients in this group, and they'll catch none of the patients in this group. And trying to stick a needle in a pancytopenic patient can be very difficult. The organs that are deep-seated may be, intermittently involved with organism. You may miss it in your diagnostic endeavor, or you may not get enough sample to yield the true diagnosis. And so the need for optimal non-culture-based diagnostics is paramount here. And I think the other thing that's really important is to have consensus definitions. And I personally find in the transplant world this very frustrating to read a bunch of single center, really great studies, but using different definitions, and it's so hard, it's apples to oranges in terms of comparison. And I think the EORTC MSG definitions are something to be aware of. They were just recently revised from 2008 into 2020 to kind of delineate proven and probable invasive candidiasis. The changes include incorporation of PCR-based testing in formalin-fixed paraffin-embedded tissues, as well as utilization of some of these non-culture-based diagnostics like beta-D-glucan and T2 Candida. And then, just this weekend, this is the frustration of, the ID team. So we had a patient pre-liver that was in the ICU, was febrile, was end-stage liver disease, was now on renal replacement therapy, had lines everywhere, fever, white count goes up, blood culture flags 3 days after we sent it with yeast. And so depending on the institution that you're at, you may not be able to get that answer, or you may have phenotypic methods, or we'll talk a little bit about some of the multiplex PCRs. That's certainly what we're using at our institution right now. But there's a rather significant lag in time. You have to then culture, sub these onto media. You have to wait at least 24 hours. And at our institution, we have MALDI-TOF, and so with early culture growth, we're able to then identify. And then you have to wait further for susceptibility data and use your local hospital antibiogram to sort out kind of what's going to be the best drug for you. And so this is an arduous process, and how can we make this better? And there's a lot of things in this, the back end here in terms of non-culture-based diagnostics, T2 Candida, beta-D-glucan, that we just don't have time to talk about, but I'm going to try to mention a little bit about a few of those. And so what we use at Duke, and there are others, similar to this, but I'm just picking one to talk about, is the BCID. And it was approved in 2013 as the BCID-1, and then this is BCID-2. And it basically is a fully automated multiplex PCR that has 33 bacterial targets. It has 10 resistance markers, and it flags, or it has targets for 6 specific candidal species. And the change from BCID-1 to 2 was the inclusion of this very important pathogen C. aureus, and it has really helped us to identify that organism and do it quickly. It has a turnaround time that's roughly an hour and has pretty good performance characteristics if you look at data from both the initial studies with the testing as well as some of the meta-analyses with pooled sensitivity and specificity data. The other thing that has been a huge paradigm shift in the microlab is MALDI-TOF, both for bacteriology as well as for fungal diagnostics. And for those of you not familiar, some labs are utilizing it directly from positive blood cultures before there's even growth on a plate. At Duke, we will sub it onto the plate, and within 24 hours, as soon as there's early growth, we'll put some of that cellular material on the MALDI-TOF plate. We apply a matrix that dries. The analyte then kind of it disperses in the matrix. You apply a laser, basically, which the matrix serves to kind of essentially to ionize the analyte through the time of flight device. And ultimately, what you end up with are very unique spectra, and we have comprehensive libraries and databases to then identify. And so this is just showing how within a specific genus and species, the spectra is quite similar. And is easily differentiated from other genus and species. And it's a really powerful tool to get a rapid diagnosis in these patients, and is also something that we're utilizing for other emerging pathogens, and we'll talk about that. There's also some additional applications that I think are really exciting, and I by no means am a microbiologist, but I think just kind of looking at the future of MALDI is bright, I think. Using it for non-culture-based diagnostics and biomarkers akin to things like beta-D, antifungal susceptibility testing, and even there was a really nice study looking at its ability to detect biofilm capacity with yeast and certain bacteria. So lots to keep our eyes and ears out for with that. I think it's important to mention beta-D-glucan because I think most of you, and maybe in the questions and when we're talking about what's happening at the individual centers, I think many of you have beta-D-glucan available to you and how best to utilize that. For our institution, it's tricky because of the turnaround time, but it's a major cell wall constituent of multiple fungi, including Candida, including Pneumocystis, including Aspergillus and other hyphomycetes, as well as some Candidiasis molds. It has received FDA approval, and there's actually recently a Fungitel-Stat, which is a point-of-care test that's now available. And it has, depending on the study, the pooled sensitivity and specificity are listed for you here. That obviously is dependent upon the prevalence of disease, but in general, I think about it as an agent that has a very high negative predictive value in terms of its application and stewardship programs. And has been used with applications to CSF with really some good results. I know in the lung transplant population, it was completely unhelpful when applied to a BAL specimen. And then I think, its role in combination with other non-invasive diagnostics, with Candida scores, with colonization population indices is, I think, where we're headed with it. And then the importance of consecutive testing. I think we all kind of know about beta-glucan and the importance of realizing the kind of false positives associated with that. In our transplant population, the things we think about the most are blood products, things like IVIG, albumin, but also there's a multitude of other things that can result in a false positive test. And I wanted to present the Candidiasis trial today because I think, well, one, it was named one of the top 10 fungal papers that changed practice at ID Week, so I think maybe worth talking about it. But I think it's for what it didn't show that it's so important. So basically, it was a multi-center trial in 18 ICUs in Germany, and they looked to answer the question whether the use of beta-glucan in high-risk ICU patients shortened the time to appropriate antifungal therapy and had any impact on what we're really looking for, which is a reduction in mortality. And patients were randomized to either the beta-glucan group, where they would use the beta-glucan to be a positive marker to start antifungal therapy, or standard of care. And the upshot is, took a lot of time to screen a lot of patients to get the inclusion criteria. And when they looked at their primary outcome of 28-day mortality, as well as multiple secondary outcomes, they did not see a statistically significant difference in the patients receiving beta-glucan-directed therapy. And in fact, these patients received more antifungals and had higher costs associated with the antifungal therapy. I will say that the mortality of the group was lower than what they had anticipated and what the power analysis was set for. Moreover, the incidence in this high-risk defined group was lower than what they expected as well. And so whether this might have panned out differently had they chosen a group that had a higher prevalence of disease, a higher risk group, remains to be seen. But for now, I think where most of the ICUs and institutions are utilizing this is in its negative predictive value in terms of stopping antifungal therapy, as opposed to using it as to start it, except for in very specific high-risk populations such as stem cell transplant and very immune-compromised hosts. And then I included in your handout some discussion around T2. I certainly today, we don't have time to discuss this in great detail, but to know that that's available. We don't have that at our institution. I think some institutions do. There's issues with cost, certainly with all these other things that we're utilizing. But just to know that this is a non-culture-based, it can detect the 5 most common species of Candida from whole blood, and it has a very rapid turnaround, less than 5 hours. So remember that slide I showed you, how long it took us to get to the end game with our blood cultures. It could really, in the right situation with the right pathogen, get you to the answer potentially quicker. And in the handout, I have kind of a pros and cons discussion for you to peruse at your leisure, but something to be aware of and to know about, because I think some centers are using it and applying it in algorithms. And then, I think I'll close the diagnostic piece on Candida auris. And I think we all, when we first heard about Candida auris, it was, the limitations of our diagnostics. And that really is no longer the case. I think we have really good diagnostics for Candida auris now. The CDC does list, for some centers that are still using some of these phenotypic and other types of diagnostics, the errors that may result. But I think if you're using a MALDI-TOF MS type identification with an updated library, you're going to adequately be able to identify Candida auris. The BioFire 2, as I mentioned to you, the BCID2, as well as the GenMark DX are all FDA approved as well, and they identify Candida auris. You can do sequencing. For research only, the T2, the MR, and molecular-based testing is available, not only from whole blood samples, but also from skin samples, but it's not yet FDA approved for that, so keep your eyes and ears posted with that. And then I think the other important thing to talk about, and we were just talking about the difficulties we're having at our own institution, is that there's no FDA-approved screen. There is a TACMAN PCR that is done by the CDC, and maybe some of you in the audience could share in the question section if you're sending yours or if you have your own home assay. But this is a problem in terms of being able to screen our patients given the lack of an FDA-approved test. And there's some neat stuff in terms of the TACMAN PCR in terms of detection of echinocandin resistance. And I look forward to this data emerging to help us to identify, particularly as we begin to see a creep in the MICs with the echinocandins and Candida auris. And I'll close with this final statement. We've said a lot about Candida and how it impacts mortality and how much we're seeing of it, but the bottom line as well is that it's impacting our costs. And I think this took me aback when you look at, these were at-risk patients that had invasive fungal infections, and they compared them to at-risk patients that did not. And if you look at invasive candidiasis compared to all other invasive fungal infections, save maybe mucormycosis, the average cost for hospitalization is staggering. And it is 5.5 times more than a patient that did not, that same risk that did not develop it. Moreover, when we're looking at these changes across time, invasive candidiasis, oh, sorry, I keep messing that up. Invasive candidiasis is shown in the pink here, and what we've seen is not only an increase in the hospitalizations, but also an increase in costs across that 4-year period that this was studied. So, this is something that's important for us to be focusing on. And so in summary, I hope that I've convinced you, if you weren't already convinced already, although I suspect you were, that this is a common pathogen associated with substantial morbidity, mortality, and burden to our healthcare system. I think, the exciting part of that is that these evolving risks that we're identifying may lead to more understanding of Candida pathogenesis. Candida auris is certainly an emerging multi-drug resistant pathogen, but the impact that it's having on you depends upon your geography as well as your geography is also important in terms of what's impacting your patients most. Early diagnosis is essential, and we need to move towards better invasive diagnostics and non-invasive diagnostics, and create studies to further define the performance characteristics and how best to utilize these diagnostics to optimize our discovery of patients so that we can apply appropriate therapies. And so with that, I was talking very fast, sorry about that, but I will pass it on to my colleague, and then I think at the end we'll have time for questions.
Thank you. All right, well, thank you. And I guess something not completely different, but slightly different is coming up. So, perfect. So glad to see all of you here. Hopefully you'll learn quite a decent amount about Candida treatment at this point. So just want to disclose a couple of things. Most relevant to this talk is I have received consulting fees from F2G and Melinta, both of whom have antifungal products. And I will absolutely 100% be discussing unlabeled uses of things as well as unlicensed products at this point. So just be aware of that. So I'm covering bullet point 3 on these learning objectives, which is implementing a treatment strategy that promotes collaboration among the lab and team members to manage patients with invasive candidiasis. And through that, I'm really just going to talk about the drugs that are available as well as some of the strategies in treating invasive candidiasis. So some of the content will overlap a slight bit, but in a directed sort of manner towards treatment. So one thing, this one is maybe a bit tricky, but I think it'll be clear later. So question 1 is for the audience response here is, what distinct antifungal classes share a mechanism of action? Do we have the 1, polyenes and urotamides, 2, echinocandins and GWT1 inhibitors, 3, triterpenoids and echinocandins, or 4, urotamides and azoles? And so let's get the ARS going. And I feel like there's going to be a bit more heterogeneity in this one than there were in the others. And that is intentional.
That was nice.
Exactly. Well, I guess the ARS didn't come up. So let's, oh, there we go. Perfect. Triterpenoids and echinocandins. So this is great. Abrexafungerp is the triterpenoid example, and they actually basically are, very close cousins of the echinocandins. Perfect. Let's see here. Okay. There we go. No. No, there we go. Okay, so here we have a brief history of antifungals, and I had really sort of stolen this slide from somebody a number of years ago, and he unfortunately has not updated his review article, so I had to keep just tagging things on at the end. So that's, that was not from the original paper. And so you can, there was over the history of antifungals, really the first things that we had were the original polyenes, nystatin, amphotericin B, and then really wasn't until the late 70s, early 80s that the azole antifungals became available, and then subsequently later on the newer formulations and more better tolerated lipid-based formulations of amphotericin, as well as the echinocandins. But now, in the last couple of years, there's really been an explosion both in the number of classes and agents that are available of drugs for invasive candidiasis and other invasive fungal infections. So most Recently, probably the most broadly used of these is isavuconazole, but now we also have ibrexafungerp, which is on the market and available for vulvovaginal candidiasis, which I won't be discussing here, but it is actually an incredibly useful drug for that if you have patients with azole-resistant VVC. And then also, most recently, we had an approval for rezafungin, which is still pre-marketing, but FDA approved, and there are a number in the pipeline, which I'll get to in a second. And so really, there are a ton of drugs in the oral antifungal pipeline, which is an incredible thing to see. Now, certainly not all these drugs are available for invasive candidiasis, but I think it's important that we be aware of what's in the pipeline. The first one I want to mention is the erotamide, olorifim. So this inhibits dihydrorotate dehydrogenase, DHODH, and this interferes with pyrimidine synthesis. So basically, it just mucks with their sort of ability to synthesize nucleic acids. This is not a drug that's active against Candida, but it is incredibly promising for some invasive mold infections like Fusarium, Scedosporium, and other of these really nasty, difficult to treat molds that we don't have good treatment options for. This is an oral agent. It's really a nice thing to have, and they're proceeding in trials for that. But again, not active against Candida, unfortunately. The next is ibrexafungerp. It's technically an approved drug, but it's still in trials for the invasive candidiasis sort of stuff. It's a triterpenoid. It has the exact same mechanism of action as the echinocandins, and it inhibits 1,3-beta-glucan synthase, but it binds at a distinct site. So it's not, echinocandin-resistant isolates are not resistant to ibrexafungerp in most cases. And so there is a phase 3 trial ongoing for ibrexafungerp versus fluconazole oral step-down therapy for patients with invasive candidiasis, as well as an ongoing open label. It does have in vitro activity against aspergillus, just like the echinocandins. There's a trial ongoing, or potential trials ongoing there. There is a trial ongoing there to see if it's useful in combination therapy. As far as monotherapy goes, probably like the echinocandins, my suspicion is it's not really a great monotherapy option, but we'll see what data shows. Next one is fosmanogapix, which is the phosphor prodrug of manogapix. This is a GWT1 inhibitor. This is just like one of these complex, mechanistic. It interferes with all sorts of cellular structure sort of things. It's not like one distinct thing it does. It just kind of makes Candida and fungus very unhappy to be alive, and it dies. And so this is, unfortunately, I think it was a very promising drug, active against a lot of molds. It was active against Candida, but this might be dead in development. And if anybody with Pfizer is here, and you can confirm that that's not the case, but my understanding is that right now it's not being clinically developed right now for various reasons that aren't necessarily related to the drug itself, but more business-related reasons, which I think is unfortunate because this is a very promising drug against organisms with limited treatment options. And the last one is encochleated amphotericin. So this is technically an amphotericin B lipid nanocrystal. I describe it as like an amphotericin B burrito or a taco. You basically take like a carbon nanotube and wrap it around amphotericin, and it's actually orally bioavailable amphotericin, which is pretty neat. It gets really bad serum levels, so it's not used or will be useful for invasive candidiasis, but for things like tissue infections. I've had a patient we treated with like a mold osteo that was very useful. So it's a pretty interesting drug. Not probably going to be useful for invasive candidiasis, but it has it's the same as amphotericin, so it has a very broad spectrum of activity against molds. So anyways, I hope I'm not dating myself with the Zoolander references, but I may have. So looking at the different pharmacologic targets of the different antifungal agents. So just looking at a cell, one of the reasons why antifungal development is different than antibacterial development is because fungus are pretty close to us. There are a lot of similar cell structures. There are a lot of metabolic processes that are identical. So this explains both why antifungals are incredibly toxic to humans in many cases because they're a shared mechanism. So when it kills fungus, it kills our cells, unfortunately. But it does provide insights into where we may be able to target fungus without toxicities. And one of those is 1,3-beta-D-glucan, because as far as I know, and none of us have cell walls, I don't think, maybe you are some hybrid form of life that has a cell wall, and that'd be great. That'd be neat to find out about. But we don't have 1,3-beta-D-glucan, and that's why the echinocandins and ibrexafungerp seem to be relatively non-toxic. Whereas some of the other things that are targeting cell membrane development, as I get to, the azole antifungals interfere with ergosterol synthesis for antifungals, but they also interfere with cholesterol synthesis in some of our CYP-mediated processes and testosterone and things like that. So that's why I have some of these metabolic effects. Amphotericin binds to ergosterol, also binds a little bit to cholesterol, and that's why we have some of the nephrotoxicity effects and things like that. Then, DNA is DNA is DNA, and so some of the things that target fungal DNA are also our chemotherapeutic agents, and that's why you have toxicity with, say, flucytosine. So it's really difficult to sort of get around some of these things, and basically the similarities between fungus and human cells is really what comes down to, or mammalian cells really, is what comes down to these problems. So looking here at the in vitro spectrum of activity, it's very important to know what's going to be active against what. And we're really going to focus on the top bit. I don't want to get too much into the molds here. That's another favorite topic of mine, but that's a completely different talk, and so won't go there. So really at the top you have the yeasts, of which we have Candida, or now the Candidas and Nicasiomyces and Pichias and whatever the heck they are. Call them Candida, please. You have amphotericin that's broadly active against almost all of these, with the exception of Candida lusitania. And then you have the azoles, fluconazole probably being the one most of us are most commonly using, but generally active against most of these with the exception of Candida krusei. And then you get to patches with Candida glabrata with dose-dependent susceptibility and varied things like that. But broadly speaking, fluconazole is active against most of our Candida, as are itraconazole, voriconazole, posaconazole, isavuconazole. You have the echinocannins, which, unless you have a pre-existing resistant isolate, broadly active. Ibrexafungerp, also broadly active. We will get into some of these, the data here. But one thing I want to emphasize with, particularly with molds, but also to a certain degree with Candida, is that the in vitro activity alone, it's not quite the same correlation like we see with bacteria, where you say it's an in vitro active drug, it probably works pretty well, assuming you can get the dose right. That's not necessarily going to be true with the antifungals, particularly in molds, especially when you look at, like, say, echinocannins and aspergillus as monotherapy. So, getting into azoles just a little bit. The azole antifungals inhibit 14-alpha demethylase, which is actually a cytochrome P450 enzyme. So this interferes eventually with ergosterol synthesis, and just like cholesterol is what sort of goes into our cell membranes and allows us to be fluid and keep everything there, ergosterol is the fungal equivalent of that. So this interferes with ergosterol synthesis through inhibiting the CYP450 enzyme. The reason why azoles have all these toxicities associated with them, drug interactions, whatever, it's not a bug, it's actually a feature of the drug. They are meant to inhibit cytochrome P450 enzymes. That's what they do. That's what they're designed to do. And so our cytochrome P450 enzymes are just slightly different than the fungal ones. So they have these sort of almost, I don't want to call them off-target because they're not, but they sort of on-target, off-target effects. And it's really just like slight differences in the fungal 14-alpha demethylase that determines the spectrum of activity for the different azole antifungals when you're talking about molds or Candida. So then comparing the different azole antifungals, we now have 5 of them that are marketed for systemic use. We have fluconazole, which is the original, well, I don't want to say the original, but it was the first really useful one. Voriconazole, posaconazole, itraconazole, and now isavuconazole, or isavuconazonium sulfate is the most recent. All of these actually do have good bioavailability for oral formulations now. Most recently we had itraconazole come up with its very cleverly named SUBA itraconazole, super bioavailable itraconazole, which is exactly what it sounds like. It's a form of itraconazole that is super bioavailable. It's a very nice drug. And so for folks with endemic mycoses, histoplasma, it's a very useful option for them. Now again, just emphasizing that from Candida perspective, all of these are pretty much broadly active. The gap being fluconazole and Candida krusei. The other expended anti-mold azoles pick up Candida krusei. And then you have sort of variable susceptibility for all of them for Candida glabrata and others. So where they differ in a lot of ways is, one, where they've been studied and also their half-life. So ranging, very short for voriconazole at around 6 to 12 hours to all the way up to like 130 hours for isavuconazole. And where that comes into play is when you start to talk about drug interactions. There is no Candida talk and azole talk that is incomplete without discussing the drug interactions. And this is where they become very different drugs and sometimes difficult to use, is figuring out where the different drug interactions are going to lie. And they all have varying substrate specificities, they're varying inhibitors. So if you have to use these in patients with oral chemotherapeutics, you have to be very specific about whether, you can have you might not be able to have a CYP3A4 inhibitor if it's with a P glycoprotein. So you can, go in here and find out what inhibits what different things. and go from there. So it's always relevant whenever I start an azole antifungal, I always double check drug interactions. And if a patient's on like a clinical trial or something like that, I always talk to the PI to check what sort of drug interactions are gonna be there. The other thing that I don't really talk about here is QT prolongation. Fluconazole, QT prolongation is also another talk in and of itself. Fluconazole does to a certain extent, but it's really not that bad. Vori, Posa, you get a lot with it. Isavuconazole actually shrinks the QT, so sometimes you'll find people like, ooh, this QT is long, let me throw an isavuconazole, make that a little bit shorter. I don't think that's an ideal situation, but it's certainly something that, folks on clinical trials can use where if, and a lot of oral chemotherapeutics might prolong the QT. Companies get very upset if you add on another QT prolonger, and so that might be the option that you have for Candida is to, get away from that. So anyways, always worth checking and double checking and triple checking, in fact, the drug interactions with azole antifungals when you start them. And the reason why this is worthwhile is this is beautiful data from Dave Andes at the University of Wisconsin, is that if you look at the number of patients who have drug interactions with azole antifungals, it's all of them. Now, whether they're relevant or not, that's for us to decide. That's what we bring to the table as pharmacists, is figuring out how to clinically operationalize these things. But you are going to find drug interactions of varying severity, most of them moderate or severe in the lexicomp sort of thing. And so when physicians go into they type in Epic and they try to order and they get like 700 category X interactions, it's for you to decide and help them sort of sort through these issues as to what they need to do with it. I can tell you that, say, posaconazole and sirolimus, it flags an Epic as an X interaction, which it absolutely is not. We can dose around that, and that's where our expertise as pharmacists come in. Okay, so now looking at the echinocandin and frankly abrexifungert mechanism. So they're sort of like I look at them as like the penicillin analogs in antifungals because they interfere with cell wall synthesis. So essentially you have 1,3-beta-D glucan that stitches together the cell wall. This inhibits that enzyme and prevents cell wall synthesis. Same as penicillin preventing cell wall synthesis in bacteria. And again, this is a target that is not shared with humans or mammalian cells. And so this is why they are relatively non-toxic compared to the other antifungal agents that we have. Looking at the different echinocandins, there are now 4 of them. Again, 3 of them are on the market. 1 of them was just approved, but pre-marketing. We have caspofungin was the original, anidulafungin, micafungin, and now resifungin. Where they differ, and to a meaningful extent, is their half-life, and then caspofungin is slightly hepatically metabolized. Anidulafungin has like these magical plasma esterases that sort of make it go away, and then micafungin just kind of disappears over time, I suppose. It's not much metabolism. All of these are very broadly active against Candida, including Candida auris, and all of them are in vitro active against Aspergillus as well. And it's important to emphasize for Aspergillus, at least, that the in vitro activity absolutely does not correspond to clinical utility, at least as monotherapy. All of these are nearly 100% protein bound, and most of these have minimal toxicity. There's caspofungin has like some dose limiting toxicity, but with micafungin and anidulafungin, you can pretty much give a lot of drug to people, and there's not going to be problems with that. Not saying you should do that all the time, but it's certainly, it's come up with, say, Candida auris, where you increase doses. They're relatively non-toxic drugs. And resifungin, we'll come back to this slightly later in the talk. Very long half-life, 130 hours, so that gives opportunity for sort of extended dosing. The others are all once a day. Then looking at amphotericin B. Amphotericin B is a polyene antifungal, and this binds to ergosterol in the cell wall, or cell membrane rather, and interferes with the sort of membrane fluidity, and the cells kind of like pop. There are a few different other mechanisms of action. It like flips ergosterol around, but basically, broadly speaking, it interferes with ergosterol's function in the cell membrane to allow this fungal cell membrane to sort of function. And this is actually a similar mechanism when this binds to cholesterol. In humans, it doesn't do it quite as well. This contributes to some of that toxicity. Certainly, deoxycholate in and of itself, the deoxycholate salt is actually an nephrotoxin, but there are other, this is kind of why there's a lot of toxicity associated with amphotericin. It's essentially unavoidable in a lot of the formulations we have. And so I kind of, maybe not the most relevant thing, but I just like these pictures, they're nice. These are the differences in the lipid formulations that are currently available. There are 2 of them. There's amphotericin B lipid complex, Abelset. And so these are little like ribbons of lipids that you kind of tuck amphotericin into, and it forms like these sort of flat monomeric sheets. Amphotericin B liposomal, Ambisome is the branded name, and there's a couple of generics now. It forms like a little micelle lipid micelle that you tuck amphotericin into, and on contact with cells, it sort of releases the amphotericin there. So these are neat. They are very distinct formulations. They are absolutely not interchangeable, and so you have to know which one you're using. Generally speaking, the less toxic one is Ambisome, and that's what most people, I'd imagine, have on their formulary at this point, even though it is unfortunately slightly more expensive. And then finally, encochleated amphotericin. Again, this is why I kind of call it like an amphotericin burrito. You just kind of take the amphotericin, you just wrap it up into this nice little carbon nanotube. And then what happens is when that contacts a cell, it goes into the macrophages, it releases itself, you have Candida in there, and it sort of releases amphotericin. So orally bioavailable and theoretically much less toxic, but those trials are going on to prove that that is actually the case. Okay. So moving into resistance and antifungal susceptibility testing. This is, whenever you give like a drug resistance talk of any kind, I think you're sort of legally obligated to show these CDC slides. And they do such a nice job, like why wouldn't you show this? It's a pretty looking slide, there's blue, there's things floating around, it's nice. Anyway, so drug-resistant Candida are a serious health threat. Estimated back in, this is 2017, 1,700 deaths and around 35,000 cases. Fortunately, actually, probably as a result of stewardship and infection control and a number of other things, excluding Candida auris, and it could also be a result of Candida auris popping into play, but excluding Candida auris, the number of drug-resistant Candida have actually decreased over time, which is a nice thing. Most of the time when we look at these figures, we see it increasing over the time. We don't like that, but drug-resistant Candida has actually slightly decreased over time, which is good. It's still not a problem, but it's a little bit less. So this is certainly on the serious health threat report. But unfortunately, Candida auris, particularly accelerated by the COVID-19 pandemic, does appear to be here to stay. And this is a nasty bug for a number of different reasons. In and of itself, it looks like a lot of Candidas. It's fluconazole resistant, and typically, echinocandida is susceptible, amphotericin susceptible. It is really hard to kill. So when you get patients who actually have infections caused by Candida auris, and I'm not going to get much into that, but most of it very frequently is colonization. But when you actually get invasive infections, it is a very hard organism to kill because it sticks to so many things. It forms really nice biofilms. And I can see Carrie singing about biofilms over there. So it really is a challenging organism to treat. And we can talk about that in questions if anybody's seen cases. The other thing, and Dr. Salo mentioned this, is that the types of Candida bloodstream infections have changed over time. So while Candida albicans remains the single most common Candida that we see in the United States, it's been replaced to a certain extent by less azole susceptible organisms and other are a little more challenging to treat. So Candida glabrata, Candida parapsilosis, Candida tropicalis. And these are unfortunately all the ones that have been renamed, and so we're going to have to learn how to pronounce things like Picaciamyces on a routine basis. But these are, they're here to stay, and they're a little bit more difficult to treat. And so now, less than 50% of all Candida at any given institution are going to be Candida albicans. And unfortunately, that means that azole antifungals are no longer a reliable empiric treatment option. So really what we get down to is that when you have a patient with invasive Candida, you have to really basically go for an echinocandin. Or, as I'll highlight in a bit, if they've had extensive echinocandin exposure, you're probably looking at something like amphotericin for some of these patients as an empiric treatment, which is a really hard thing to swallow, but it is what you have to do in certain circumstances. And the reason for this is, at any given day, how many of you just show of hands, how many of you folks have a person that you're like, why the heck is this person on fluconazole in the ICU? How many of you? I see pretty much universal acclaim to that. And the problem is with using that fluconazole for why the heck is this person on fluconazole is that it selects away all the Candida albicans that if you're going to have a candidate, we want you to have Candida albicans. But unfortunately, it selects away for that and it gets replaced with things like Candida glabrata, gets replaced with things like Candida krusei that are less susceptible. And you can see here is a nice just figure showing, this is from Barnes-Jewish, just showing how pre-exposure to azoles influences subsequent epidemiology. And then what happens when these patients do eventually develop invasive candidiasis, if you start them on an azole, you're wrong in a lot of cases. In about 2/3 of cases, it's going to be the wrong therapy if you have previous exposure to fluconazole. And then, unfortunately, like all nice things, if we use them, we select for resistance. So we have some nice data from Duke, nice data from Houston, nice data from Pittsburgh. Anybody? No Pittsburgh people here? Pittsburgh, as soon as we get nice, oh, there you are. As soon as we get nice things, Pittsburgh decides, no, you're not going to have that new drug anymore, and they break it. And so this is what happened immediately with the echinocandins. And so what happens is in these patients, just as we saw with fluconazole, echinocandin use in some of these disastrous intra-abdominal infection cases, multivisceral transplants, whatever, selects for echinocandin resistance. And these are the patients where you unfortunately are pretty much pegged into using empiric amphotericin when they actually do have candida, because there's a good chance of them having echinocandin resistant candida or candidiasis, and they have a really high failure rate when you subsequently treat them with echinocandins in this scenario. So it's not necessarily everybody. It's not meaning everybody who's had an echinocandin before. But if you get the right patient who has like this chronic necrotizing pancreatitis, they've been on echinocandin for like 6 weeks for no reason, and then all of a sudden they have candida in the blood, sorry, you probably got to use amphotericin for that person, unfortunately. Then one thing to emphasize, and how many of you do not have antifungal susceptibility testing in-house? That is way more hands than I want to see. This is an available thing. Would any of you treat bacteria without doing susceptibility testing? Anybody? Why do you do it with candida? I know that it costs more money. It's not justifiable. There are very few things where I can say that on, but you would not treat a patient with a bacterial infection without doing susceptibility testing, and you should not do that with candida. And so if your lab is giving you pushback, work with your lab, figure things out. If you're in a small critical access hospital, figure out somewhere to send it in an expedient manner. But it's not something that you should be doing. And given the epidemiology of candida now, unfortunately, we can't reliably use these options. And you can look at the Sanford guide and be like, I should be able to use it for, Candida parapsilosis or Candida tropicalis. That is unfortunately not the case anymore. We need to have susceptibility testing. It's available in a number of different ways. E-tests, if you really need to do it, you can use those things. But work with your lab to figure out a way to do susceptibility testing, at the very least for invasive Candida isolates. I'm not saying you have to do it for all urine. In fact, you probably just don't even need to report the Candida in the urine, but you really should be doing susceptibility testing. Okay, so now looking into treatment of invasive candidiasis. Which, and this is again, I'm sorry, it's a trickier question. Which of the following best describes the reason for lack of non-inferiority? And this is a weird way to phrase it, but it's the way I have to do it with a non-inferiority trial. What is the reason for the lack of non-inferiority of isavuconazole compared to caspofungin for invasive candida? Is it A, increased mortality, B, increased time to blood culture clearance, C, increased clinical failure rate, or D, increased adverse events? Some of you are skipping ahead, I can tell. It's a problem with handouts. I can give away all my secrets. So it is, in fact, increased clinical failure rate. And we'll get to that in a moment. So as Dr. Sullivan mentioned again, candida treatment is a spectrum. It starts off with no disease. And these are certain patients that in very high-risk scenarios, we provide them prophylaxis. So these are your prolonged neutropenic patients, hematopoietic stem cell transplant patients. They're at such high risk for invasive candida, we give them prophylaxis. It's appropriate to do so, and in fact, that's a mortality decreasing intervention. So for patients with leukemia to give them candida prophylaxis, it decreases their mortality. It's a great thing to do. Then you get to this sort of gray area, which is a real pain in the neck to deal with. There's the high-risk asymptomatic patient. They're in the ICU. They're on TPN. They've gotten like 700 all the antibiotics we have in a row. They go from Pip/Tazo to cefepime, metronidazole to Vanco. They never really had anything. They got candida everywhere, whatever. And that was the beta-glucan study, the Septifast study that showed that it did not provide any mortality benefit if you initiate antifungals there. Then you get into the empirical. So these are the patients who are on broad-spectrum antibiotics in that same scenario, and they continue to be febrile. And even then, it doesn't really help if you treat candida there. Then you get to full-blown disease, and these are the patients who have candida. They have it in the blood, they meet the EORTC MSG criteria, you pull it out of like some abscess from somewhere, and you know they have invasive candida, and these are patients you absolutely should treat because they have invasive candidiasis. And then you have, sort of sequelae and readmission. Depending on your patient population, this is a huge problem. So one thing is absolutely true. This is nice data from Kevin Gary, and many others have duplicated this. This is no different than we see with bacteria. Is that if you know you have something in the blood, or a bad thing in the blood, most things growing in blood are not supposed to be there. mortality rises with delayed treatment. So the longer you wait from the time you've identified Candida, if you wait for the 2 days for the organism to grow, you're already behind the 8 ball, and mortality has increased. So same with antibiotics. With antibiotics at least, we don't typically wait till we see bacteria in the blood in a septic patient. We decide we're going to treat them empirically, wait, figure, peel things off later. The same would be nice to apply to antifungals, but unfortunately, as we see, that does not work. There have been multiple randomized controlled trials that you identify super high-risk patients for invasive candidiasis. Septifast is another example. This is the Empiricus trial published a couple of years ago. A decade before that, there was a fluconazole trial that was published. It does not work. When you identify everybody, you can look at them and you say, this is the highest risk patient I can think of in my ICU right now for invasive candidiasis, and you give them empiric antifungal therapy because you think they're going to have it. It does not work, and that is the problem, and that's why we need to get better diagnostics. Maybe beta-D-glucan was supposed to be there, but the septifast study just showed that was not the case. So it really is an unfortunate sort of gap in our knowledge of what we're supposed to do with these things in terms of diagnostics. Many smart people are working on it, many people much smarter than I am, and they still haven't figured it out, so I don't deem to think that I could figure it out right now. But it is an unfortunate fact of the matter. And you can slice and dice this data however you want. Increasing severity of illness, increasing number of lines, increasing Candida everywhere. The Candida scores, they just unfortunately do not work. So now, avoiding that issue altogether, once we know a patient has candidemia or candidiasis, what is the treatment of choice? And this is, again, from Dave Andes. He's a very smart guy. He did this patient-level meta-analysis of echinocandins versus azoles for treatment of Candida. 5 minutes? So we have this data right here that kind of shows you that, there's some disputes about this, but even accounting for resistance and everything, there's some hints and mostly probably true that echinocandins are preferred to azoles when you have a susceptible isolate. Now, this shows a 35% relative risk reduction for mortality relative to azoles when you start with an echinocandin. This was a weird sort of study because they put together all the randomized controlled trials, and there were only a couple that directly compared echinocandins and azoles. But anyways, even not accounting for the resistance issue, and I'd say just on the basis of the amount of azole resistance that we have, echinocandins are what you have to use for invasive candidiasis until you have susceptibility testing. But the interesting thing is, does that hold up in contemporary clinical trials? And I would challenge you to find a more superimposable Kaplan-Meier curve than this one. And this is the mortality data for isavuconazole versus caspofungin for invasive candidiasis. Isavuconazole, not approved for invasive candidiasis. It certainly wasn't because of mortality. It was because of increased clinical failure rate, which was related to things like ongoing symptoms of disease. Not disputing those by any means, but if you happen to put a person on nasal up front for whatever reason, you don't have to look at it and say, like, I'm failing this patient whatsoever. There are, it's maybe not the drug of choice, but there are circumstances, and you don't have to worry that, mortality has increased 1,000,000-fold or something like that. So it really just is a sort of interesting thing. But that said, azoles absolutely do have a role for step-down therapy. We have verification from a couple of randomized controlled trials, including the isavuconazole trial, where they stepped down to PO isavuconazole for some of these patients. And it's absolutely fine. You have no difference in global response, clinical response, microbiologic response if you have a susceptible isolate. Now, Candida glabrata is susceptible dose dependent, which doesn't really have much data supporting that if you have low MICs in that range. But when you get into like the 32 range for susceptible dose dependent, that is not a place where you want to use an azole. You're not going to be able to get the exposures you need there. And so just like if anybody was in my classroom this morning when I said cefepime susceptible dose dependent is a sort of fake thing, I think azole susceptible dose dependent is a little bit of a fake thing for invasive Candida. And if you go to Europe, that category just doesn't exist at all. So depending on what side of the Atlantic Ocean you're on, should not make a difference as to whether fluconazole is going to work or not. But I guess it does. So anyways, but you absolutely 100% need susceptibility data to make these switches. And we need ASP help to do that, stewardship people. So this is data from Houston that if you have a fluconazole susceptible isolate, 17% switch to an echinocandin anyways. Why? I don't know. Patients with on echinocandin with fluconazole susceptible isolates, only 39% of those get switched to fluco. So you need to do antifungal stewardship and educate people as to the viability of this treatment option. And so I'll end this up with rezafungin. This is the new one. And I'll put on my best Seinfeld voice with what's the deal with rezafungin. So this is a new echinocandin. Again, it has a very long half-life. It's a 130-hour half-life. And it probably has what are optimized PK/PD for echinocandins, which is a front-loaded dose. echinocandins are AUC to MIC drugs. So, and in animal models, the higher the initial echinocandin dose you give, the faster the candida goes away. So this did have a small licensing trial, a phase 3 trial that was recently completed. It was a pretty small study, actually. It was only about 90 patients in each arm, rezafungin randomized against caspofungin. And you can see the mortality and the global failure there. It's dosed once a week. So this trial, they did 400 milligram load, 200 milligrams once a week. It went from there. It has a very similar spectrum of activity, AE profile to other echinocandins. This doesn't really get into anything related to the drug, but it was a 20% non-inferiority margin, which is a huge margin. Are you going to say that 19% of people more could die and count that as an equivalent drug? This didn't come close to that, so it's just more of a gripe that I have with the FDA and the way they license products. But anyways, the thing is, the role is yet to be clearly defined. It probably will have a role in terms of step-down therapy for patients who cannot get azole antifungals due to non-susceptibility to azoles or due to drug interactions or things like that. There's an ongoing prophylaxis study, which I'm very eagerly awaiting those results for patients with high risk for candidemia. And there are going to be some other studies in the pipeline. But right now it does seem to be an equivalent product for invasive candidiasis to caspofungin. But given what will ultimately be cost considerations and things like that, it probably doesn't have much of an acute care role, but certainly will have a role in probably long-term management of patients with invasive candidiasis who otherwise can't get oral therapies. The other thing that'll be interesting in the pipeline is ibrexafungerp will have a similar role for that as oral therapy. So which one's gonna, where things will shake out, we'll have to see sort of post-marketing data, how things ultimately are used, and susceptibility information. So in summary, we finally have a pretty decent antifungal pipeline and a decent variety of treatment options, which is nice. These treatment options are good. Resistance, I hope I've shown you, is absolutely important. And for the folks of you, I understand that this happened, who raised your hands for not doing susceptibility testing, work with your labs to figure out how you can do that in a manner for your patients. And then echinocandins are the initial drug of choice, but oral azoles do have a role still, particularly as step-down therapy. And so with that, I think we're on to the Q&A.
Is there an optimal time for fluconazole oral step-down therapy, let's say in like a critically ill patient that is in ICU on echinocandin?
I don't think there's going to be any. This is on. I don't think there's necessarily going to be any difference between what you would do for oral step-down therapy to say a quinolone or say a highly bioavailable beta-lactam for patients with a bacterial infection. So usually my practice would be once they have achieved clinical stability and you're reasonably certain they have a functional gut, then you could do that. I don't think that actually, and similarly, once you have identified a fluconazole susceptible isolate, if you want to switch them from an echinocandin to fluconazole, even IV, I think that's probably fine. We don't really have data for that, and I don't see that there's a need to do so that early. But generally for oral step down, I approach it the same way I would with bacteria. Is once you have, a couple days of treatment, they've cleared therapy, their clinical stability, switch them.
Is the emergence of CRs related to global warming?
You've been reading very good review papers. Do you want to take that one?
Sure. I think that is certainly one of the theories, is that global warming has resulted in them being able to be thermo and salt tolerant, and then birds bringing them into the environment, and then agriculture changing their resistance profiles, and then them landing in the healthcare system. So that is certainly part of the concern. I think that it remains to be determined, but I think that is one of the postulated thoughts. I think it's changing the way we, think about Candida, because we just don't think about healthcare outbreaks with Candida albicans, although with propsilosis, perhaps maybe a little bit more so. But yes, to answer your question.
With propsilosis, there is a clear trend in changing susceptibility.
In certain parts of the world, I was listening into some of the talks at ICAC, and in certain parts of the world, they are having substantial.
Locally in Florida, at least Aventura, and So no, I was just mentioning that we have seen a shift in susceptibility. So that idea that it's C. parapsilosis, you'll be okay with fluconazole is no longer the case for any of the Candida species, I would say.
Right, right. No, I think the Sentry data, the global data would show that. I think it's important to look at your own antibiogram. At our own institution, we just recently updated ours, and we have not seen too much in the way of resistance, but it's really dependent upon the patient, where they're from, and what your local antibiogram is. But it's not 100% in terms of susceptibility.
And certainly when I made the comment earlier about the sort of Sanford-style picking of Candida parapsilosis is actually the one that I had in mind, because that's one where you traditionally think, yeah, I can use fluconazole, and that's what the Sanford guide says, but it absolutely, depending on your hospital and where you are, that is absolutely not the case any longer. And that probably is, to my mind, the best use case outside of Glebrada and echinocandin for antifungal susceptibility testing is parapsilosis.
Other questions? I have a question here for both of you. What would you say is your most challenging obstacle issue that you are having in treating invasive candidemia? And is it missing the diagnosis, or is it really resistance?
Well, so I guess I think our biggest challenge is in the transplant population is the issue of source control, and I specifically am speaking to the treatment of intra-abdominal candidiasis in our abdominal transplant population. That source control oftentimes is very difficult, and then long-term exposure to echinocandin can result in resistance. I'm happy to report that our resistance data is not as bad as that which you presented from our 2014 data, but I think that can be very challenging in patient populations where you're unable to obtain source control, and you know that over time that exposure is going to result in resistance.
Mm-hmm. Yeah, and I think to me the biggest challenge, and this is not going to be unique to my institution, is really figuring out the patients who have Candida before you know they have candidemia. It's the natural instinct is to want to treat them, and it's very unfortunate that clinical trials evaluating that for early therapy have failed, because we know that there are patients who will benefit from antifungals before we know they have Candida in blood, and identifying who those patients are is very challenging. Things like T2, things like beta-D-glucan are fraught with challenges, and figuring out the patients who to use those things on is also quite difficult, and then what to do with some of those results is quite difficult. And so I think that is still remains, and it has been the biggest issue in candidemia for 30 years, and I think it probably will be the biggest issue in candidemia for another 30 years, frankly.
Since you're talking about rapid diagnostics, who's ordering the rapid diagnostics for this testing? Is it exclusively ID physicians or other physicians in the ICU ordering, for T2 or any of the other rapid diagnostics?
So we don't have T2 at my institution.
Well, any of them.
It depends on the situation, but at least at my hospital, ICU physicians do occasionally order 1,3 beta-D-glucan, and I believe that because of that, we have essentially the results that we're seeing in the SEPTIFAST study, where it's being used probably inappropriately so for its positive predictive value, where they see a positive result, ignore the fact that the patient's on CRT and gotten like 700 doses of IVIG in the last week, and say, ooh, it's positive Candida, and treat, and rather than relying on the negative predictive value, which is probably the best utility of it. So, and I think our ID docs, when they order it, they make the same mistake, frankly. People see a positive test and it turns red in the chart, and they like to treat that result.
Is that the same for you, Jennifer, too?
Yeah, no, I think the same. I think I'd say in terms of some of the rapid diagnostics, the BCID, the multiplex PCR, and the MALDI-TOF is part of our laboratory standard. But in terms of things like beta-D, we also do not have T2 Candida. But in terms of beta-D, well, I think one is related to our geography. We are in North Carolina, and I learned when I came from New York that North Carolina and New York are very different in terms of our invasive mold infections. And so we use a lot of anti-mold prophylaxis and antifungal prophylaxis. And so the use of these screenum the beta-D-glucan, the galactomannan in populations where there actually is utility is limited because we already have our patients on prophylaxis. And then similarly in our ICUs, I think that there is a role for its negative predictive value in maybe taking away antifungal therapy, perhaps in addition to some sort of Candida score or colonization indices. However, for our institution, the problem is we don't have it on site, and so it's a turnaround time issue. And so it's just really not helpful in real time, and so for that reason we don't. But it would be our ICU and infectious disease colleagues that would work together to algorithmize that.
Okay. So if you've treated Candida auris infections, what did the susceptibilities look like, and what did you use, and what was the outcomes?
Yeah. So, I mean, it's Candida auris is, how many, just curiosity, how many of you folks in the audience have actually seen an invasive Candida auris case?
Looks like a lot.
Invasive, like in blood? Wow, that is way more than I was expecting, actually. Yeah, and so it's quite sporadic. I noticed we have folks from Detroit here that raise their hands, and a lot of places that have a big LTAC population will see probably more Candida auris. In Michigan, we had a single case that was non-invasive so far identified in Michigan Medicine. Even when I was at MD Anderson, which you figure if you're going to have Candida auris, you're going to have it there. I think I had one patient with Candida auris in blood. So typically from the epidemiologic data, what you would see is that they tend to be fluconazole resistant, and broadly speaking, they're echinocandin susceptible and amphotericin susceptible. The problem is we don't know how to optimally treat those, and this is a case where I absolutely think in vitro susceptibilities do not correlate with outcomes, and it is very hard to kill Candida auris. So you often end up using combination therapy, including amphotericin-based regimens, higher dose echinocandin regimens. But for the folks who have had this experience, because I do not, and the published literature is sparse, I'd be curious what you're doing. So you've seen several cases. So how have you treated your patients with Candida auris?
Well, with difficulty.
Yeah.
So a lot of these patients have actually been chronically infirm, nursing home type, and deep wound infections, bone infection we've seen, and candidemia as well. So we've routinely been using echinocandins and plus minus amphotericin B as well. So we've done, I think that most of them, I haven't really seen any fatality, from the organism, from the candidemia. We kind of manage these patients alone, and kind of, I can't speak of microbiological cure. I don't think that's possible with this organism because it just hides in there, and it may be multiple wounds. We've seen that.
Yeah, and so actually, let me ask this for the folks who did raise your hand in terms of having seen invasive Candida auris. How many of you does anybody feel that they typically do respond to standard therapy with just normal dose of echinocandin? I'm not seeing any hands for that one, which means that we probably do have a Candida auris treatment problem. We need to better define how to do these sorts of things, because I think that is a huge unanswered question. And like some of these things, maybe Candida auris will blip away. I don't think it will. I think it's probably here to stay, and so I hope we get better data on how to do these sorts of treatments soon.
Well, maybe you don't have much in Michigan because it's cold.
Yeah, no, I mean, it's weird. We have a ton in Detroit. It is, everything in Detroit is resistant, and they've created Vanco-resistant Staph aureus there. Sorry, Mike. But, at some point, like between Detroit and Ann Arbor, which is like 45 minutes away, there's just like this hard block on resistant organisms, and there's nothing in Ann Arbor. It's strange.
So I have a question for the audience. If you had a patient with AKI and has pyelonephritis, grows out Candida glabrata, can we still use amphotericin?
Sorry, what was it? I missed the...
If you have a patient with AKI, pyelonephritis, grows out Candida glabrata, can you still use amphotericin?
I mean, it depends on the circumstance. I certainly would not want to, but if it's a patient who I know has a echinocandin-resistant glabrata, then yes, I would. In an empiric setting in that, if it's a person who's been on, it's a tough call. It's going to depend on how much echinocandin they've had and all sorts of what the circumstance is, and that, how would you approach that?
Yeah. I mean, and we still, every once in a while I have one that's fluconazole susceptible. So if it was, I certainly would be using that. It's got great urine and parenchymal penetration. But I think the echinocandin comes across the question of the fact that it doesn't have good urinary penetration, but does have good parenchymal penetration. And so treating that would be an option. But yeah, I would try to avoid amphotericin in situations such as that, if possible.
Mm-hmm. Yeah, and don't get me wrong, I don't think there's, the circumstances in which you use empiric amphotericin for glabrata would be few and far between, but it's worth realizing that that's not outside of the realm of possibilities for things that you might have to consider doing.
Okay, Sam, since you brought up susceptibility for antifungals, is susceptibility correlated with outcomes?
Who asked that? Was that a
By
question?
the way, don't forget to see Carrie LaPlante's
Carrie, thank you.
symposium tomorrow on MICs and breakpoints.
Yeah, and so, it's an interesting question, and certainly there are not maybe the best clinical evidence, but there are data that suggests that, at least for Candida albicans, that you have increasing clinical cure rate with the AUC to MIC ratio or dose to MIC ratio. So in that case, yes, you need to have an MIC to define the denominator there. Where the MICs are also probably correlated are going to be Candida glabrata and echinocandins, where the echinocandin MIC is really a surrogate for FKS mutations or mutations in the target gene. Beyond that, whether fluconazole MICs correlate in any meaningful way to outcomes for patients with susceptible dose-dependent isolates, who knows? And I imagine that's why you asked the question. So it's really an unclear thing.
Okay. I'm not sure exactly I understand this question, but someone's asking, how would you do a study on antifungals for Candida auris? Is it hard to enroll for this study? Is that what you meant by that?
I mean, I guess it depends on your center. At Duke, it would be very hard. We have not had a case. I'm sure that we also have not, we've had issues with turnaround time in terms of our screening. But I think you certainly want to have that in a place where you can enroll patients. So, where we're seeing the clades 1, 3, and 4 in the United States would be the places to do that. I guess the big question really is, it seems like it's headed towards whether an echinocandin, right now the resistance rate is 2 to 3%, but that we're seeing definitely this MIC creep on therapy in patients that are treated with the echinocandin monotherapy. So I think one of the big questions would be whether a combination therapy, whether that be an azole and an echinocandin or a polyene and an echinocandin, as opposed to monotherapy, is really the right, what's the right approach? I think the combination therapy question is already out there and being asked.
There's a question about the role of fungal blood cultures. I'm not exactly sure, but whether it's timing or how often do you get it, but what is the role of fungal blood cultures?
You don't really need them using modern, at least for Candida, using modern blood culture collection systems, which are more sensitive. They have good growth media, and Candida tends to grow. You're not going to increase the yield essentially by holding them for a longer period of time. You can use the fungal isolator tubes, but they're labor intensive and challenging. And really, for standard modern blood culture techniques, you do not need them for Candida. They probably do still have a limited role for things like endemic molds like histo and other rare yeast, but as far as Candida goes, there's not much. I don't see much utility.
Yeah, no, similarly, I think for the endemic, and then TPN, malassezia, we certainly use it for malassezia, but otherwise I think standard blood cultures and just really making sure that you're getting adequate volumes it's important, but they're quite sensitive if you're catching the patient at the right time when they are actually candidemic.
Okay. I think we're going to end, we got a question here? Okay.
Not that I'm aware. I mean, it's it's in the guidelines for Candida endocarditis combination therapy, whether it's necessary there. Candida endocarditis is a very challenging disease to manage, and the data is extremely limited. I personally do not buy the combo therapy data for the combos as recommended, and I just don't think so. Urine sterilization maybe, but the patients who actually have Candida cystitis are few and far between, and I've not seen them respond to therapy. I certainly can clear Candidiasis with it, but I think that's not a disease really. That's just a thing that's Candida in the urine. So I don't think there's much of a role for 5-FC personally in Candida. Cryptomeningitis is a different story, but I don't see much of a role.
We definitely use it in chronic meningoencephalitis cases. I mean, not like I've treated millions of those, but we have had cases and we have utilized that based on MIC data and the organism. And so that's, I think, the situation where we've used it most.
Okay. We're going to end here, but I want to thank our two speakers for the enlightening symposia today. Thank you.